Thank you for all for being here. It's really great to see so many people interested in this topic and learning more. I'll introduce myself in a few minutes, but I just wanted to go over our quick little agenda. So I'll introduce myself. I have two brief sort of case studies. And I should say, obviously, the topic of today's conversation is, eating disorders and disordered eating among boys and men. And it's, again, targeted towards sort of learning more information, understanding some nuances of these behavioral sort of presentations. And hopefully you'll leave today with some more knowledge, of course, of this area, but of also some sort of tangible techniques and skills and information for you to bring to your practice. I do use the pronouns he and him. So again, I'll introduce myself. I'm going to go over like two brief case studies just for us to reflect and think about eating disorders among the population that we see. I'll give kind of a broad overview of eating disorders among boys and men. And I'm going to talk about some of the like body image nuances and behavioral nuances that often do focus a little bit more on like muscle enhancing behaviors and muscularity. I will provide some basic statistics and sort of overview of kind of how often these behaviors present. Then we'll talk about barriers to treatment, which is obviously a huge issue in the eating disorders community, but also and particularly among boys and men. And then what to do, how you can sort of assess and engage, boys and men in treatment. And we'll go into question and answer from there. And then NEDIC and Sheena's place will also offer some information about their services. So just briefly, who am I? I'm an assistant professor at the Factor-Inwentash Faculty of Social Work at the University of Toronto. I'm a new assistant professor. I just started in July of last year. And my research has focused predominantly on adolescent and young adult health, though more specifically on eating disorders and muscle enhancing behaviors, performance enhancing substance use, and violence victimization and perpetration. Mostly, again, within the sort of male space, boys and men, but of course sort of expands to all people. And I've had 7 years of direct social work practice experience, and I've worked in a variety of settings. So I know, I sort of know the sort of nuances of being on the front lines, if you will, working with people with eating disorders and the challenges. Also sort of know some of the nuances of the barriers and sort of lack of information sometimes people have. So I'm really hopeful that you leave this session with some more information you can bring to your practice. And my clinical experience has been, not surprisingly, with focusing on boys and men with mental health issues, with eating disorders, though obviously that's a very nuanced area. So it's often not that many men and boys, but seeing a lot of boys and men with depression, anxiety, OCD, things of that nature as well. So that's a little just introduction of who I am. What I'd like to do, I know that we have a lot of people here, which is super cool. We're not going to sort of share out in this moment, but if you want to just do a quick self-reflection for yourself and think a little bit about like, who do eating disorders affect? What do eating disorders, quote unquote, look like in this population? And how has your personal and clinical experience influenced this perspective? So just take a moment to sort of be a little non-judgmental and just sort of reflect on your own personal, just like experience in the world, and also your own clinical experience or clinical training, and think about who eating disorders affect and what those eating disorders look like. So I'll give you about 15 or 20 seconds or so. Okay, so hopefully you have some kind of picture in your mind, some sort of understanding of what eating disorders look like. Again, I'm putting that in quotation marks, and sort of who they affect, based on preconceived notions, based on popular media, based on clinical training, things of that nature. So I'd like to talk just briefly about a typical case of anorexia. So Kaylee is a 26-year-old cisgender woman. She presents with significant history of restricting her food and purging via vomiting. And she continues to engage in these behaviors despite significant weight loss, including like less than 80% of her ideal body weight. And she reports feeling quote unquote fat and is dissatisfied with her body despite her weight loss. So this is sort of what we would typically think. I think specifically too in popular media and social media, we think of eating disorders as this typical case: a cisgender woman, mid-20s. I think you probably could sort of go deeper into this this sort of fake case and think about, race, ethnicity, maybe socioeconomic status, and think sort of about, I mean, even this image of To the Bone, which is a Netflix movie, kind of portrays this very similar, very, very sort of stereotyped case of anorexia nervosa. Some of you might have been reflecting and thought about this type of case, right? Cisgender woman, maybe white identified, higher or like middle socioeconomic status, focused on eating and weight behaviors that are on weight loss and body image towards thinness. That's sort of this typical case of anorexia that we might sort of understand and commonly see in treatment settings, for sure. Sorry. Now, what about boys and men? So Peter is a 16-year-old cisgender boy. He participates in cycling and track at school. He denies engaging in these typical eating disorder behaviors like fasting or restricting or vomiting. His parents report he's obsessed with increasing his athletic performance. This has led him to alter his food consumption to mainly lean proteins and food supplements, and the elimination of fats and carbohydrates. Along with track or cycling practice, he trains for an additional 2 or 3 hours a day on his own and has reduced his social events given this exercise and food regime. So I think it's important to think about this case in relation to the previous case and think about, does Peter have an eating disorder? And if so, is it anorexia? Is it bulimia? What would we call this? Are his behaviors problematic? And how might social norms approve or promote these behaviors? How might you assess his behavior? As in, if he was come to your office for whatever reason, or you're a school social worker and he comes to your office because of issues in class or something, how might you ask him questions or assess this behavior? What questions might you ask and why? And then, of course, how might you intervene? What interventions would you actually use to help him? These are important questions for us to be thinking about with a case like Peter, because he's not presenting in that typical, quote unquote, typical sort of eating disorder presentation, which we might see from the case of Kaylee. And so these are just some questions that I'm hoping that you'll mull over as we go through this presentation. And maybe towards the end, you can sort of reflect back on the case of Peter and think about, okay, now I have more information, now I have more knowledge, now I have more skills in order to actually assess and intervene with a case like Peter and understand maybe the behavioral nuances that he's experiencing that are different than what this typical case of eating disorders would be. So generally, eating disorders in boys and men have, the research in this area has been quite lacking. There has been a more significant increase in that research recently, which has been really obviously important. But to date, most of the body image and eating disorder research is focused on the experience of girls and women. Most of the body image research is focused around drive for thinness and typical, quote unquote, typical eating disorder weight loss behaviors like restricting or purging. Even eating disorder research on binge eating disorder is still fairly under researched and lack of knowledge in that area, despite being very, very common compared to the two other sort of main eating disorder diagnoses. And of course, binge eating disorder does affect more. It affects more males in a more comparable way to females. In general, less than 1% of body image and eating disorder research has focused specifically on boys and men. Oftentimes the research is combined with women. And so there's like this lack of knowledge is really key. And I'm sure you can think about your own experience as clinicians, being with clients and not having adequate research to be able to truly treat and understand the nuances of the people presenting to your practice. Compared to the idealized sort of body ideal for women, which is often just thinness, right? I mentioned that before. The idealized body ideal for boys and men has focused on increasing muscle mass and muscularity, and I'll talk about that in a few minutes. And of course, if the increasing muscle mass and muscularity is the common sort of body image ideal, is what men and boys are striving for on a more general terms, that of course has led to increases in attempts to gain weight, build muscle mass, and decrease body adiposity, which is essentially decreasing body fat. And that's sort of a consistent pattern we've seen over time. And so I want to actually highlight that. by a few different sort of images. So this is an old study. It's from 1999, but Pope and his colleagues actually gathered 30 years worth of action figures, male action figures, and actually measured their body and sort of did an analysis of how their bodies has changed. And these are the images they present in their article, and I think they're quite emblematic. And of course, this is in 1999, so it kind of it ends in 1994, which is obviously 25 or so years ago. It's a pretty long time ago. And so I think it's just important to think about this is then and this is now. And we're in 2021. I'm sorry, my dog is about to bark, so I'm going to mute myself just to let her out really quick. Hold. All right, sorry about that. The trials and tribulations of doing these things from home. So you can see from these images that the bodies of these common action figures like G.I. Joe and Han Solo and Luke Skywalker have significantly changed over the years. You can see that they're more muscular. You can see they have bigger muscles, more defined muscles. You can see that their like V shape has changed, like higher, like wider shoulders and skinnier waist. So this is sort of emblematic of the change we've seen in the male body image over time. And I'll highlight that again by showing some more images of these ideal bodies that we experience in social media and in athletics and in movies by Cristiano Ronaldo and The Rock or Dwayne Johnson. And I highlight these two because they're actually, Cristiano Ronaldo is the #2 highest most followers on Instagram. He has like 276 million followers. And Dwayne Johnson is #4. He has like 230 million followers. And so, I think it's just important for us to think about how many people are following these guys and seeing images like this. If you look at The Rock's, page, you'll see him in the gym. You'll see him working out. It's a pretty consistent pattern for him in his Instagram feed. And so again, this is highlighting the images of boys and men, of men and their body image, and propelling this norm of muscular, lean, cut, and strength, athletic performance, which of course drives the body image experiences boys and men experience. And so, of course, this increases risk around aesthetic sports. So things like where the body is more visual and seen, and also sports that are more focused on weight, like wrestling and cycling and, football, things of that nature. I also highlight football too, because you can't really watch a football game without hearing about the football players. And I'm talking about American football, the football of, their body size, how much they weigh, how tall they are, how fast can they run, things of that nature. So all of this leads to this internalized body ideal that boys and men experience. And I'll show one more because I'm from New England. So Tom Brady is kind of like a very important person around here. But this is his combine photo, which is right before he got drafted in 2000. And so you can see he doesn't look like an athlete. He looks like a normal dude, I guess. And then you can see this is an image of Men's Health, which I think was actually just recently was published. And it sort of shows him, well, obviously a lot more cut, a lot more, physically fit, has much more of like the sort of ideal that we would sort of anticipate a male athlete having. Now, I would also highlight too a couple things about this image of him on Men's Health. One is you can look at the articles that they're promoting, things like Muscle Up, Slay Stress. There's the inside the OR with the man boob king of Texas. Like these are the body image, again, internalized body image messages that we are sending to boys and men and promoting in everyday sort of popular culture. I also highlight Tom Brady because he's also part of a more nuanced sort of body image and behavioral sort of pattern where he's sort of in this biohacking, which I'll talk a little bit more in a few minutes, but biohacking is essentially trying to optimize the body's performance, which again, in a world where, boys and men are trying to, or are oftentimes thinking about ways to sort of be better in athletics, look a certain way, perform, cognitively, mentally, physically, psychologically in really high stress jobs or high just highly, that's a sort of area you're trying to optimize your body in a really specific way. He has this unique pattern of behaviors called pliability, where he's just trying to outlive time, and he's like 45 years old and still, winning the Super Bowl. So he's optimizing his body in really unique ways. He's promoting his TB12, which is his like pliability and food and supplement industry stuff. So just another nuanced, side behavioral pattern that's happening that we should be aware of as clinicians and sort of be critical of and think, is this actually helpful, or is it actually not helpful for the people, the everyday people that we see in our practice, or that are being missed in our practices? Okay, so, and as I've mentioned, just sort of an overview here. So oftentimes boys and men are seeking this muscular ideal, as we saw from the images of Cristiano Ronaldo and The Rock and Dwayne Johnson. So this leanness, this muscularity, strength, things of that nature. This leads to these various array of behaviors like weight gain attempts, excessive exercise and weight training, protein overconsumption, intermittent fasting, which I'll come back to. Bulk and cut cycles are where you sort of eat maybe more or higher caloric, food over a week period, let's say, and then you do a cut cycle where you eat only sort of salads and, like less calories. And it's meant to sort of catalyze your metabolic system and reduce body fat and things of that nature. Again, it's a little bit of like a binging and restricting cycle, if you will. Cheat meals, which are often objective binge episodes, like allowing yourself to eat whatever you want on a certain day because you were quote unquote like good, or you followed your, regime for, a certain number of days. Certain dietary restrictions, like restricting things like food, fats, and carbohydrates, similar to what we saw in the case of Peter. And then of course, performance enhancing substance use, like whey protein, creatine, anabolic steroids, all very common. Again, the goal is to increase muscularity, increase leanness. And so these different nuanced behaviors are meant to do that. It's important to recognize, similar to the eating disorder, experience, that these behaviors happen regardless of weight status. So, oftentimes even boys who are like objectively within a sort of normal weight, if you will, again, like BMI is not always the most accurate categorization of weight. But even boys who are and men who are in sort of normal weight ranges, let's say, do engage in weight gain attempts or different types of behaviors like this of this nature. And I'll highlight the intermittent fasting because, again, that's another sort of biohacking behavior. It's meant to sort of trick your cells and into sort of optimizing in a specific and unique way. I think there's like some preliminary research that it can do some, help with sort of things like maybe diabetes and potentially prevent cancers. So there's like some nuanced research that says it's like helpful. But of course, it's also a restrictive pattern. So for example, like Jack Dorsey, who is the CEO of Twitter and obviously very well known and very wealthy, again, another emblematic figure that boys and men may look up to. He only eats one meal a day. He eats dinner and that's it. And he's been very public about this. And it's something that many people know about. So again, contextualizing these behaviors within the social media and the popular media is obviously very important, particularly around people who are of privilege and sort of higher popularity. So I just laid out all these behaviors. Some you might be reflecting on and being like, I've never heard of this before. You may be reflecting like, well, not that many people do these things. That can't be true. But in fact, there's actually a lot of research that shows how common all of these behaviors are. So for example, in a recent study among Canadian young adults, 17 to 32, 23% of men were reporting that they were trying to gain weight and 6% of women, which is pretty consistent for the US as well, as far as statistics. And most people, the most methods used were eating more food among women. So 85% of women who said they were trying to gain weight were eating more food. And 72% of men who said they were trying to gain weight were eating more protein. Again, not super surprising, but almost a quarter of men in Canada between the ages of 17 and 32 are trying to gain weight. Again, emblematic of that larger body, muscular, more lean sort of body ideal. This was an older study, but 42% of boys as young as 10 years old in Canada, and 36% of girls were attempting to gain muscle. So it's a little bit older. But it's important to highlight that actually almost half of the boys and over a third of the girls are trying to gain muscle. So again, it's the influence of this more fit muscular ideal that's perpetuating young people's minds. And food supplements like pills or steroids were common among these populations. So 7% of boys and 8% of girls. I'll highlight that there's a little bit of nuance there, because including pills and steroids together in a sort of question in a research is a little bit misleading, because it's probably pretty likely that fewer of these participants were using steroids and more of them were using like supplements, like some sort of pill or some sort of protein powder or something like that nature. So I wouldn't equate that 8% of girls are using steroids, just to put that out there. And then similarly, 25% of boys and young men and nearly 4% of girls were using muscle enhancing behaviors. And that was sort of categorized as like dieting in a certain way, or exercising, weightlifting, taking food supplements, all as a mechanism to gain weight and enhance muscles. And nearly 16% of men between the ages of 18 and 26 were using legal performance enhancing substances. So and I'll talk more about these, but these are like creatine and whey protein. So these are like over-the-counter things you can purchase at your local pharmacy. And nearly 3% reported anabolic steroids. So that's a pretty high percent of people, of boys and men who are using steroids, which is obviously quite concerning. So are these behaviors problematic? So obviously we've now seen that they're happening at fairly high prevalence. But thinking about them as if they're problematic is obviously really important. Now, muscle enhancing behaviors may pose risk for the development of muscle dysmorphic disorder, which is a subtype of body dysmorphic disorder, which is in the DSM-5. Muscle dysmorphia is commonly known as like bigorexia or like reverse anorexia. And it does disproportionately affect boys and men. But this is sort of categorized by this preoccupation or obsession with this insufficient muscularity, wanting to be bigger, even though maybe already big, or maybe already muscular, maybe already lean. And this sort of cartoon is a little bit silly, but I think it does sort of characterize this disorder. So looking at guys like you, and I say to myself, wow, I hope one day I can get that big. So there's sort of like a similar sort of cognitive process that happens where there's a distorted view of one's body, despite actually being what they want to be. So of course, muscle dysmorphic disorder is a serious problem and can be, a sort of outcome of these behaviors. Importantly, muscle dysmorphic disorder is not underneath the eating disorders classification. It's underneath the obsessive compulsive and related disorders classification, which I think is important for us to be thinking about, because we sort of treat these behaviors in a certain way. We sort of assess them in a certain way based on sort of DSM diagnostic criteria, which of course will guide our treatment and guide our assessments and programming. So just something to be thinking about. Okay, all these problematic. So again, performance enhancing substances are actually quite problematic and can be actually really harmful. So for steroids, we know a lot more about steroids. And so again, remember the 3% of young adult men report using steroids, which is obviously a big problem. And they're associated with things like mood disorders, aggression, violence. We know that steroids are associated with teen dating violence, substance use disorders. And of course, there are like an array of cardiovascular and neuroendocrine, musculoskeletal, renal, liver, all these different systems of the body, they can have really poor and adverse outcomes. So again, 3% of young adult men are using steroids or have used steroids. That's a fair amount of people. And so just thinking about these sort of poor outcomes that may come of it. Similarly, legal performance enhancing substances, these are more like over-the-counter things you can purchase at the pharmacy, at the grocery store. And these are less research. There's less knowledge about how they might be problematic and what sort of outcomes may come of it. What we do know is that they're associated with like problematic alcohol use, like binge drinking. We do know that they're associated with like severe medical events, like hospital visits, ER visits, and even death. They're associated with future use of anabolic steroids. So if you use these legal performance enhancers, you're more likely to use steroids in the future. They're of course associated with muscle dysmorphia, like I mentioned. Things to really know about these substances, especially given how common they are. Again, remember 16% or so of young adult men are using them. So that's a fair amount of people. They're largely unregulated, just like many food supplements that you might buy. They're easily accessible. You can go to the store, you can just purchase them. They may be contaminated. There's been plenty of studies that have shown that these legal performance enhancers are contaminated with things like stimulants and even anabolic steroids. Also that their labels don't actually say exactly what they are, what's actually contained in them. So lots of sort of issues with these supplements. And oftentimes they don't actually really produce the effects that people are intending them to produce, which of course leads to further substance use or further performance enhancing substance use because it's not actually helping them the way they want to have it help. And I'll put out a little experiment for you to sort of think about next time you go to like the local pharmacy, like a Shoppers or your grocery store or something, just like take a look. I mean, I know the Shoppers that's like across the street from my apartment. If you go to the pharmacy, and you look down, there's just like creatine and whey protein and like all these different supplements that are these legal performance enhancing substances that many people are using and choosing to use to help them, get to that ideal body image that they're hoping for. Okay, so those were some of the major sort of areas of these muscle enhancing behaviors, things that maybe are sort of really nuanced in particular to the male eating disorder experience and disordered eating experience. But I want to talk just briefly about some of the DSM-5 eating disorder diagnoses and some of the sort of knowledge we have about that, because of course, boys and men experience sort of traditional, if you will, eating disorder diagnoses. And so I think it's important to note that 95% of all cases of full syndrome, so like full eating disorders, based on the criteria, the DSM-5, will occur before the age of 25. And that includes for both men and women. So we know that young people are much more at risk than older people, of course. And of course, these are rates that will be sort of steady until the age of 30 or so. And 1 in 7 men will actually experience eating disorder by the age of 40. So that's a pretty high percentage of boys and men, or men, I should say. And I think that if I remember correctly, it's 1 in 5 women. So pretty high, pretty comparable for the most part to the experience of women, despite the fact that we don't see as many men in treatment, despite the fact that we don't always think about them in our treatment and in our assessment processes and treatment processes. And generally, a good rule of thumb is that adult men account for 1 in 4 cases of anorexia and bulimia, and 1 in 3 cases of binge eating. And so again, despite some prior statistics that used to say 1 in 10 cases of eating disorders were men, it is much more sort of a higher prevalence than we obviously think about. In Canada, it's estimated that close to 3 million people have an eating disorder. This was, I believe, if I remember correctly, in Ontario, but a little over 2% of boys among community sample met criteria for a DSM-5 eating disorder diagnosis, which is a pretty, again, it's only half of what that for girls, and it's pretty highly comparable. And as far as like young adult men, a little over 1% of males were diagnosed or treated with anorexia in the past 12 months, and a little over 1% were diagnosed or treated with bulimia in the past 12 months. So, again, these are sort of small numbers, but I guess if you expand them to the general population, there's actually a fair amount of people of boys and men who are experiencing these eating disorders. And again, these are full syndrome eating disorders. So full syndrome, DSM-5 classified eating disorders, which is obviously, that means that these smaller like behavioral nuances are obviously going to be happening at a higher prevalence, like the use of supplements, the use of substances, maybe the restricting, maybe the binging and purging, or just straight binging. Those sort of behavioral subclinical behaviors are obviously going to be happening in a higher prevalence. Importantly, boys and men are often more likely to report significant sort of adverse outcomes, and sometimes at a higher rate than women will. So some research has shown that boys and men experience greater psychiatric comorbidities like substance use or psychotic symptoms associated with their eating disorder. Not surprisingly, there's often a later age of onset, typically in later adolescence, though it's hard to really fully grasp that because we don't assess eating disorders among boys and men as early as we would for a woman or a girl. So there may be some sort of challenges there as far as our processes of assessing. Boys and men are often likely to have a previous history of obesity or being overweight and experience some sort of weight-related teasing. And I think it's important to note that just as more research is coming out about weight discrimination and weight-related teasing and stigma and all those things among the general population, among women, there's also, that is coming out among men too. And so men are not immune to weight discrimination and are often experiencing these weight-related bullying or teasing that could influence the development of eating disorders. So, and relatedly, non-heterosexual and transgender boys and men are also oftentimes more likely to experience body dissatisfaction, eating disorders, and disordered eating and weight control behaviors. There's been a plethora of research that is obviously coming out about these disparities among, again, all people, but particularly boys and men who are not heterosexual or transgender do experience these nuances and higher than their sort of cisgender or heterosexual peers. And a lot of that is minority stress. A lot of that is, just in general, using the behaviors as a mechanism to maybe adhere to a body that is more aligned with gender identity, things of that nature. So really important to be hyper aware of disordered eating behaviors among this population. Similarly, non-white boys are likely to experience a similar disproportionate experience of body dissatisfaction and disordered eating and weight control behaviors. And again, minority stress is often explains that. And so it's just important to be really hyper aware of your own sort of bias or knowledge or experience or understanding of how eating disorders present among boys and men, and make sure you expand that to include non-heterosexual, transgender, non-white boys to be inclusive and make sure that the assessment and treatment process is happening among this population. And of course, certainly most of the research is focused on young people. That's not surprising given that young people are most at risk. But in a study in the US found that almost 7% of men between the ages of 40 and 75 reported eating disorder symptoms. So these behaviors are across the lifespan and do impact men at all ages. So don't just walk away thinking, oh, this is just a young adult male thing and young adolescent boy thing. Like this is something that happens to and experiences for all men. So despite these statistics, we know that treatment utilization remains really low for people with eating disorders, unfortunately, but it really is actually even lower for boys and men. So these are a few studies I like to highlight. At a clinic, over a 21-year period, only 5% of the assessments at this clinic over a 21-year period were boys and men, which is obviously a very small percent given the number of people and the number of percentage of people who experience eating disorders in the population. And similarly, 10% of adolescent boys with eating disorder will seek sort of emotional treatment or mental health treatment. So again, like 1 in 10 who are experiencing these behaviors, will actually seek treatment. Obviously a major issue, because, we know that the longer the eating disorder is present, the more it develops and sort of becomes more solidified and the treatment becomes more difficult. So it's just important to be considering that. So now I'm going to pause for a second and you can think a little bit about all we just talked about. I've given you lots of statistics. I've given you some information about, social norms, I guess, social expectations of boys and men around body image, different nuances of behaviors. And maybe you can just spend, 10 or 15 seconds sort of thinking about why are so few people boys and men coming to treatment, and maybe what those barriers might actually be. So, spend 10 to 15 seconds just thinking about that. Okay, so hopefully you have some ideas and we'll see if they align with my next slide. So major issues that affect boys and men seeking treatment. One is obviously societal and self-stigma. So certainly the more stigma that one experiences related to an eating disorder, the less likely, and I say a person, I think for boys and men, the less likely they are to have a diagnosed eating disorder. So actually experiencing stigma around the eating disorder prevents and is a barrier for the diagnosis of an eating disorder. So really important to understand how much stigma boys and men experience as it relates to eating disorders. Another major issue is just poor mental health literacy. So actually this was a study in 2014, a qualitative study that asked questions of men with eating disorders. And a lot of them just were like, I didn't know this was a problem for me. Like I knew it was a problem for other people, for women, but I didn't know it was a problem that I could actually experience, despite the fact that they were engaging in the behaviors themselves. So just not even knowing, not even having this knowledge or education of, hey, this could be a problem for me, is obviously hugely problematic. Oftentimes treatment spaces are geared towards women and girls. This is something I experienced as a clinician in eating disorder treatment programs, that despite the fact that they may only treat women, despite the fact that, and I'm coming from the States where there are programs that sort of only cater towards certain populations, the environments are not welcoming. The environments are very much geared towards a sort of girls, female sort of space. And that could be just the colors on the wall. It could be the decorations. It could be the quotes on the wall, things of that nature. So thinking about sort of the treatment space as a barrier is obviously very important. And I would encourage you all to think about your own treatment spaces and how that may or may not create a barrier to the people some people you might work with. Another major issue is just poor assessment measures. I mean, most of the assessment measures we have, and I'm going to go over a few newer ones that are come out recently, that focus on eating disorders have been developed and normed for women and girls. So there's a huge problem with just using assessment measures or diagnostic measures. Misdiagnosis, lack of diagnostic categories. So again, thinking about that case of Peter, if Peter showed up at his family doctor or a therapist, they may not actually know to think, oh, this is an eating disorder or this is disordered eating behaviors. They may question it. They may think there's some red flags. They may be concerned about it, but it may be that they don't actually think that there's a true problem here around the eating disorder process. And as I mentioned, there's no formal diagnosis that considers these muscle enhancing behaviors. Muscle dysmorphic disorder is probably the closest thing we have. But it doesn't actually capture the true nuances of those muscle enhancing behaviors. Lack of knowledge among healthcare providers, healthcare professionals. That's a sort of general eating disorder, knowledge we have about general eating disorders. Many times people like medical providers experience very few hours of medical training around eating disorders, which is obviously, really important. I think one of the studies I referenced once was less than 5 hours of their whole training was on eating disorders, which is, given the amount of people in the population who experience them, is obviously problematic. Lack of evidence-based treatment. So we actually don't know the best way to fully treat a lot of these disorders among boys and men. A lot of the studies, like randomized controlled trials, are specific for women, and there's an inclusion criteria around that. So that obviously creates barriers. And similarly, there's no medical treatment guidelines that are tailored toward boys and men. A lot of the medical guidelines are focused on women and female experiences, and how to help them. So these are like a ton of barriers, obviously, and lots of them that we need to sort of break down over time, but certainly something to be sort of thinking about in the back of your mind. Assessment strategies. So we move from barriers to assessment. How can you actually assess and engage boys and men? Of course, we know that assessment is the first step to treatment utilization. So if we want to break down those barriers, if you assess, if you're on the lookout, if you're keeping your eye open for some of these behaviors, that's obviously going to be a very helpful process for you to get people into treatment and utilize treatment. So some strategies: assess body dissatisfaction and concerns specifically related to this muscularity and muscle mass. If you're thinking about this, if you're keeping it in your back of your mind, and just assessing around body image around these issues, that will be a huge important issue. Assess male eating disorder related behaviors. Again, that focus on this gaining weight, increasing muscle mass and tone, decreasing body fat. It's important to assess a range of these behaviors. So not all, people might, be trying to gain weight, but they're not using any of this more specific behaviors. And sort of think about this range of behaviors and not just one specific. Assess frequency, dose, intensity, and duration. So these are obviously important sort of understandings of assessing whether there's a true problem. I mean, certainly a young person who is, exercising regularly, not to say that protein supplements are bad altogether. If they're using it appropriately or as recommended, like that's probably okay. So really making sure you understand the nuances of the behaviors is really key to a properly assessing. Use a variety of measures. So if you're in your practice and you use validated measures, it's important to use a variety of them. I find that if you use eating disorder ones that, again, may not be fully, normed to boys and men or developed for boys and men, but you're using them and they give you some red flags, and you also use a muscularity-oriented, eating measure, and you use a body dissatisfaction measure, the more measures you give, sort of the more, culmination or a fuller picture you get of the person. So just, think about using multiple measures is key. Assess functional impairment, sort of like I mentioned before. So thinking about psychological, social, occupational, what are the impairments that this person experiences? And then sort of pathological thinking styles. So like, is there anxiety? Is there control? Is there self-esteem issues? Like, how are these issues related to the behaviors that the person is engaging in? And then also, avoid using body mass or weight just to determine whether to assess for eating disorder. That's a general comment, but I think it's very specific among boys and men too, because again, we know that these don't necessarily look, these might not look like a traditional eating disorder. The weight loss may not be there. Actually, the weight gain may be happening. So don't use weight as a general tool to be like, oh, I'm going to assess this person or not assess this person. So given those sort of assessment recommendations, maybe take a second to think about what questions you might ask. Boy comes to your room, young man comes to your room. They're talking to you about some of these, maybe you ask them about body image. Maybe think for a second just a little bit about how would you ask questions? How would you phrase questions around these issues? So take a minute, or not even a minute, I'll do like 10 seconds, and I'm going to show you a few example measures. Okay, so maybe you've thought about a few ideas, and I'm going to show you a few newer tests that have come out recently that try to capture this muscularity-oriented eating or body image experiences among boys and men. This one's called the muscularity-oriented eating test, or MOET. So you can see I've highlighted just a few here, and you can sort of see how they capture the nuances of not only male eating disorder experiences, but also those like psychological processes, the social processes. So the first one, I've recorded macronutritional values of everything I eat. So again, really getting down to the sort of the biohacking sort of science of eating, which is a little bit different than maybe the female experience, which might be more around reducing calories or reducing fat. I cannot achieve my body ideal unless I exert complete control over everything I eat, right? A very similar experience you might see for a female and a sort of traditional eating disorder, but thinking a little bit about this complete control, that's a psychological process that these people are experiencing. I have been deliberately trying to limit the overall volume of some foods. That's that like targeted supplementation, so that my muscles look more defined, right? The purpose is for muscularity. It's not for thinness. It's for muscles. And then ensuring proper adherence to my dietary ideals is more important to me than adhering to my work schedule. There's like the social nuance, having some interference with socialization. So again, thinking about muscularity, thinking about functional impairment, psychological thinking, those are key areas here. And then eating for muscularity is another sort of new scale. And again, I've highlighted very similar, measures here. So this one is the first one, number 8. I've restricted my carbohydrate intake when I missed an exercise session. So there's some compensatory behavior happening. There's some very targeted, I'm not eating carbohydrates because I didn't work out. I have altered between bulking and cutting or shredding cycles. So again, those are those bulk cut cycles where you're really trying to sort of trick the body into reducing body fat and build muscle, alternate between the two. I have given up important work commitments to maintain my diet schedule. Again, social impairment. I've used diet methods to become more muscular. Again, methods meant for muscularity, not so much thinness. And thinking about food and eating and calories made it very difficult for me to concentrate on things that I'm interested in. So, again, functional and social impairment, psychological impairment, focus mainly on these eating disorder and disordered eating behaviors. So those are just some, really important you don't have to use these scales per se, but I think these are really important questions that you might actually want to, translate to your practice, especially if you're seeing boys and men, to just assess. It doesn't necessarily mean they have an eating disorder or are engaging in all of these behaviors, but to fully sort of capture an understanding of what behaviors and body image issues they may be experiencing. Okay, now we've talked about barriers and assessment. So now some engagement strategies. So like I mentioned, in general, boys and men are a lot less likely to seek mental health services. That's very well known, just around socialization processes, some lack of just maybe emotional awareness, emotional attunement, etc. So just understanding that that's a prerequisite in many ways for most, not all, but most, is really important. So understand and be compassionate towards these socialization norms. Most boys and men are socialized to be tough, stoic, lack emotional awareness, be independent. Again, not all boys, it's not an all or nothing, but it's maybe more of a most men, boys and men. And then this is all compounded by the stereotype that eating disorders affect only girls and women. So thinking about how boys and men engage treatment, like we saw in some of the barriers, like some of the guys didn't even know they had a problem, despite the fact that they were engaging in the same behaviors that they knew was a problem for the women. And reflect on your own predisposed notions of eating disorders as it relates to gender and sex. And I would expand that to race, ethnicity, socioeconomic status, etc. So thinking about, like I asked you to sort of think about that at the beginning, be very conscious of why you ask some questions of some people and not other people. Stereotypes of eating disorders, body ideals, muscle enhancing behaviors, etc. They hurt all boys and men. And that's sort of, I've mentioned already, but that's especially for boys and men who are sort of farther from like the real man narrative or real man stereotype when it comes to gender expression and presentation. So just make sure that you think about engaging all boys and men, understanding that all boys and men have a body image, have a reflection of their own space, body in space, have a relationship with food. And not sort of categorizing it just based on one presentation over another. And then for treatments, like I said, there's not a lot of information about specific treatment modalities that are most effective. But in general, I would encourage you to use an array of intervention strategies. So we know that CBT is quite effective for eating disorders and different body image issues. Things like motivational interviewing could be very helpful around like substance use, or especially if there's a really significant substance use problem. Family-based treatment is obviously very helpful for people with eating disorders. So again, depending on context and capacity, those can be important mechanisms for treatment. So in general, I would say use as much as you can based on what's within your practice limits, based on what your own practice and clinical experience is. And your own comfortability, and also what you think is going to be most helpful based on research around eating disorders. And yes, I already mentioned that overall, there's just little research on the effectiveness of multiple treatments around males. And my final takeaways are my summary. Boys and men experience unique body image concerns that are focused on muscularity, muscle mass, and leanness. Boys and men engage in unique eating disorder behaviors that aim to achieve this ideal. Despite the fact that some of them do experience more traditional eating disorder behaviors. Boys and men experience significant barriers to treatment that can lead to lack of diagnosis and treatment, resulting in poor prognosis and outcomes. So again, all the more reason to assess early and to intervene early. Little research has been done on best practices to engage boys and men in treatment. And I'll just emphasize that you can actually make a huge difference here, because if you screen boys and men, if you ask questions around body dissatisfaction, eating disorder behaviors, if you integrate that into your process with boys and men, in general, despite the fact that you might not even work with boys and men, with eating disorder clients, more regularly, but the more you engage and get into a practice of using these questions, the more you'll catch it, the more you'll be able to intervene effectively and help people along the way. And so that leads me to the end. I'm going to I think we'll do some Q&A first, and then have have Sheena's place, so have Ari and Caitlin talk about their programming. But I just wanted to quickly say a quick thank you to everybody for being here. This is my email, so if you do want to like connect with me via email, have questions, I'm happy to answer any questions, outside of if something comes up. If you'd like to follow me on Twitter, you can certainly find me on Twitter, where I do post like recent research and things of that nature. So those are two avenues. I'm going to stop my screen share now. And yeah.
Cool. Thanks so much. And Caitlin's spotlighted me because I've had some questions come in through the chat. And so for folks on how this Q&A is going to go, you can see that there's 185 of us in the room, which is fantastic. And we'll open up the chat at the very end for folks to be able to say thank you to Kyle directly too. But if you feel like you have really specific questions for that, feel free to pop them through me. I'm happy to do some filtering and see where there's some themes and see how we can best use some of the remaining sort of like 15-20 minutes that we have for this. And so some questions have already come in, and I will name first. Kyle, no pressure on feeling like you have to answer all these questions. I think they're we can always pass and give some other informational resources in the chat. One thing that's come up from a bunch of people is the impact on family sometimes. And there's someone who asked, if a family member has a young boy or young man in their life, what are some things that they might notice that might be different than what we stereotypically or typically see around eating disorders?
Yeah, I think that's a great question. And I think families, especially for boys and kids who are living at home, obviously it's hugely helpful to have families who are aware. But I think in general, just being aware of comments about body, comparisons about body. I mean, similar things that you would experience for girls and women, right? Being really curious about why they're starting to work out more, why they're limiting their caloric intake and or limiting certain groups. Like, I think just being very curious. I always use the term respectful curiosity for, families and parents. Tell me more about why you decided to start taking this protein supplement, or tell me why you think exercising an extra hour after your practice is going to help you. Just trying to gather information, be really curious about these behaviors. And just understand that, just because, they're trying to work out more doesn't mean they now have a significant problem, or because they're using a whey protein supplement, like doesn't mean they have a significant problem. I think it's just about being aware, understanding that, sometimes these behaviors, just like, eating disorder behaviors that can start out very small and turn into something really big. We just need to know that understand that these processes happen on a similar continuum, or can happen on a continuum. Just like regular traditional eating disorders, if that makes sense.
Cool. Thanks so much for sharing that. And for those who asked that in the chat, feel free to follow up with me in the chat, and I can pose that to Kyle. Yeah. There's a person who's asked, as you've nicely mentioned, so many of the behaviors are normalized, like not eating carbs when missing a workout, or trying to gain muscle, or intermittent fasting. Are there specific pieces in your language as a practitioner that you've noticed that you've tried to become more conscious of and aware of, or things that you've tried to take out of your vocabulary or insert into your vocabulary that you want to share kind of from an eye perspective on this?
As far as what specifically? What do you mean? Like as far as assessing?
Yeah, like the ways in which we're sensitive about being like the normalization of that, like how they're socialized, the ways that we maybe talk about weight, and the ways that we talk about body with boys and men.
I think it's just I think first of all, naming it, being sort of naming that these are, I think if someone comes in and they're talking about restricting carbohydrates, or, wanting to, I get like ads on Twitter and Instagram all the time for intermittent fasting apps. And they must know that I do like eating disorder research or something. That's why they're sending them to me. But like talking about and having really, blunt conversations, if you will, like, what's your understanding of this behavior? Really like, why do you think this is going to be helpful for you? Where are you gathering this knowledge and information? And I think that's something also it's important, is we don't always know, we don't actually always know like how these processes fully develop. Certainly, we have risk factors, like there's risk factors like body dissatisfaction and things of that nature, but we don't fully know like how does a boy or a male, or even a woman or a girl, decide to sort of download this intermittent fasting app and then use it, or how do they learn more information about that, or how do they learn more about protein supplements that are going to be effective for them. So I think asking those questions of like, how did you learn about this? How, where did you learn about the information that this would be helpful? What's your understanding of it? And I think just naming, like, naming some, learn more about the research, learn more about like what may or may not be true about some of these behaviors is obviously quite important. So I think that would be if I answer the question correctly, I think that would be my sort of recommendation is really just name them and sort of debunk the myths that may actually be out there. And I'll also share about the risks, right? Like I did share some risks with you about using some of these supplements and some of these behaviors. So naming them, putting that out there and letting people mull over them and understand them within the context of their own experience is obviously key.
Cool. Thanks so much. And for that person who asked that question, feel free to let me know in the chat if I've relayed that effectively. Some folks are asking, and there's a bunch of these sorts of typical things, so I'll try to merge this question together, on resources specifically for boys and men around positive body image. And I think folks are generally looking for client-facing resources. So if there's certain books or certain like videos or things that you feel like you often are sharing with folks that might be helpful in a general way.
That's a really good question. There's not a ton, I'll say that. One documentary that I think, this is not a book, but I think a documentary that I think is really good and I recommend for clients and clinicians and people to watch. You may have heard of it. It's called The Mask You Live In. And it was made by the same people who did Misrepresentation, which is all about female and male and body image among girls and women. And the sort of, I guess, like sexualization of girls and women. But The Mask You Live In is really about the male, socialization process. And it sort of talks a little bit about body image. I mean, again, it's mostly around just like norms of male development and boy development. But I think The Mask You Live In is a really good documentary that would be helpful just to contextualize. Again, not all boys can experience the same thing. It's maybe a most situation, but just the socialization process. I can think of some others that maybe I can sort of like tweet out at some point or something. I don't always remember the name of this publisher, but it's called, I think it's GURZE, GURZE, is an eating disorder publisher. And they publish a lot of books that are around eating disorders for treatment, but also around like lived experiences of people with eating disorders and healthy body image. And my hunch is that if we looked at their catalog, they would have some good books that are specific for male body image. Yeah, that's what I would say. But I don't have any off the top of my head, sorry.
Cool. No, thanks so much for trying to answer that question. There's a couple of things in here that I think I'm going to take the first stab at, and Caitlin, feel free to unmute for this one too. And then Kyle, feel free to chime in on it too. There are some folks asking about research specifically with BIPOC folks, Black, Indigenous, and people of color with eating disorders. And the person's mentioned culturally, sometimes there are many issues due to socioeconomic and food security issues. And depending on where you grew up, sometimes one meal is realistic and not actually a symptom of an eating disorder, but just the consequence of food security. And there's someone else that's asked similarly, how can we help eliminate the gap in treatment and provide eating disorder treatment and awareness to those from racialized groups with a history of food insecurity? So one thing that I'll name, at least to start, is I really appreciate these questions. I think like this nuance is really important. And I know both NEDIC and Sheena's place, I think, are really passionate about trying to do work in this area, to the extent that Caitlin and I, from a NEDIC and Sheena's place perspective, are going to be running a webinar series, likely in the summer, around eating disorders and food insecurity specifically. So just for those who are attending this, we're going to try to have a variety of voices who are on there, both folks speaking from a food justice and food advocacy perspective, but people who have lived experience of having to go through that issue, and then some researcher and clinician voices who are able to talk about how to specifically work on that, because I think you're absolutely right that it's there. And I think we all have to be really mindful of, when we're asking some of those really wonderful questions like Kyle posed, to be mindful of like that socioeconomic often context and racial context of which a client might be coming in, and assessing like what's normal for them, right? Usually a symptom is meant to be an issue when it's a change from their normal. And if their normal has been that, then I don't think we want to pathologize something that's often an economic issue and not a mental health issue. And so I really appreciate that question. Anything you want to note on that, Kyle or Caitlin?
Yeah, I would just echo what you're saying. I mean, I think it's so important that we just expand our our understanding and of eating disorders away from just this norm and this bias that we've experienced for so long now, and certainly understanding things like food insecurity and food insufficiency as huge problems, and yeah, trying to figure out ways to make treatment more accessible for these individuals. And assessment more effective for these individuals is just, yeah, it's just like hugely crucial. And so any way we can do that is, and I think it just starts with coming to things like this, going to other going to other webinars, and just learning more information, learning more sort of, quick questions you can ask, or just assessment processes you can engage in to raise red flags and just know what to do next, essentially, I think is key.
The only thing I'll add just very quickly is along the similar lines is if a person is experiencing food insecurity, as clinicians, we need to know where we can help them get support for that. So instead of trying to find a free eating disorder treatment or support program, maybe it's more simply about access to food. So how can we help them from a socioeconomic perspective first, before addressing the eating disorder, because that might in itself solve or help the problem.
Absolutely. I know when Caitlin and I get to have the privilege of getting out to go to community and doing outreach and education presentations, one of the things we always ask is like, in addition to your mental health resource list, like, is a food bank actually on there? And knowing that sometimes it can be really difficult for people to feel like they can speak up and ask about that. And for us as providers, having that information just there, because sometimes it might be hard for people to access it. And I don't think it's people's fault sometimes for not being able to figure out where they need to get that information. So thanks for that. I see some hands up. And so one thing I'll name for the hands up folks is that this is recorded. So if you don't feel comfortable actually sharing that out loud, feel free to just pose your question in the chat. But Tahira, and I hope that I'm pronouncing your name right, and please correct me if I didn't. If you wanted to unmute and ask your question, you can give it a go.
Hi, my question is not like really a question. It's just something, information I would like to tell you. All the time I was looking for help as a parent was this, that my child disorder was not looking big. And here what I get was that everybody was talking about, like, when I was getting help, that you got to go look big, you got to get bigger. For my child, the disorder was not to go big. And he was crying constantly to not to get big. And when I was seeking help, everybody was telling him to go big. And his eating disorder was to not go big. I don't understand it, that here, even in this webinar, it was all that, the dysmorphia is about getting muscles and all that. His disorder was to not to get muscles. He started 500 calorie count a day because of not getting muscles. But just starting exercising and all this. It's been over a year now. I'm trying to seek help. He's just a kid. And here, psychiatrists are not getting him medicine because he needs a consent. They need a consent from him. But he will never give a consent. He won't, because it's a disorder. I don't understand it, what the system is. I'm following the NEDIC for ages, but I'm not getting any help from the system. Can anybody help here? I don't understand it. Yeah, that's it.
Thanks so much for sharing that. I can take the first stab and then folks can share. I think one thing that's really important is that eating disorders are as diverse as the people that they affect. And so sometimes when we're doing presentations like this and trying to give information to a bunch of people, we'll often talk about what's impacting a lot of folks, just to try to make sure that that information is getting transmitted to everyone. But I think where an individual, where one person falls on that kind of continuum of concern is always going to be different. And it sounds like the person in your life, Tahira, like, is experiencing something that's really concerned. I really believe you when you share that. And that the system should be listening to you, and people should be paying attention to that, because that sounds like a concerning experience, and that sounds like something that can certainly be an eating disorder, and restriction, not wanting to eat and wanting to be thin, is something that impacts boys and men too.
Yeah.
I think we really wanted to make sure that we're emphasizing that, since that's the narrative for girls and women, we wanted to make sure that people knew about the muscularity pieces here, because it does affect a lot of boys and men too. But I think your experience is totally valid. These things really don't discriminate across gender or race or body type. I'll let Kyle jump in on that if he wants to.
Yeah, I would just agree. Like, I think one of the takeaways from this presentation, I hope, is that yes, in a more general sense, oftentimes these behaviors present in this muscularity, weight gain, muscle building sort of phenomenon for boys and men on a more general, again, I would say most is that's the experience, but that doesn't mean that men are immune to more quote unquote traditional restrictive sort of eating disorders that are a little bit more like what we might traditionally think about as far as boys and as far as for boys and men, and within the context of sort of traditional eating disorders. So yeah, the system should be working. Unfortunately, it doesn't sound like it is for you, and that's too bad. But it doesn't mean that there's not a problem there just because this person's experience is more aligned with maybe what we might traditionally think of as an eating disorder.
I think this is maybe a good time too, and I know that there are other questions, and Jennifer in particular, I see your hand. We wanted to make sure that before we let everyone go, that we have a chance to talk to people about getting help, because we know that that's something that's there, and it's something that NEDIC and Sheena's Place both do. So I'm going to transition over to Caitlin to be able to talk about Sheena's Place programming, and then I'll talk about NEDIC programming after.
Yeah, so just very briefly, I'll outline what we do for anyone who might not be familiar. So Sheena's Place, contrary to what the name may suggest, we are open to people of all genders. So I know that the name Sheena can sound feminine, and that can be misleading both for service providers and people looking for support. But all of our we offer free group-based support for people with eating disorders and disordered eating. So a person does not need a diagnosis or a referral. Everything's free of charge. And the only criteria are that a person must be at least 17 years old and accessing our groups from Ontario. I know we have people all around the world on this webinar today, so we'll provide more information if that's relevant to your area. But many of our groups are full at the moment. However, we do have drop-in support groups that are, again, open to anyone 17 plus in Ontario. And so for information about that, you can send me a message on chat. I'll put our website in the chat as well. And so boys, men, trans and non-binary folks are welcome to access any of our groups. And yeah, I guess I'll leave it at that. The only other thing I will say is that we are collecting information about barriers for some specific groups of people, including boys and men, in order to be able to better address certain populations to access support. So I will put information and the link to that survey in the chat. So if you are someone who's experienced an eating disorder as a man, cis or trans, or if you're a clinician with clients or patients who have experienced this, then we would love your feedback.
Cool. Thanks so much, Caitlin. And I'll share my screen just to do the NEDIC spiel for folks, just to let you know. I feel like especially for those of you who still have questions after this webinar, I really want to let you know that we have the privilege of operating Canada's national toll-free telephone helpline and an online chat service for people who are struggling with this issue. The chat part is actually really easy, and so you should see this little green chat button at the bottom right of your screen when you go on our site. You can enter whatever kind of name you want, so feel free to put in whatever kind of nickname, your pronouns if you feel like you want to, who you're seeking information for, and hit start chatting. And you're able to chat with someone usually within a minute during our operating hours. We're happy to help do some system navigation for you. So for those of you who are parents, people personally affected, wanting to find some sort of help, we're happy to help navigate you through our publicly funded system and some of the private system. We have a service provider directory where we can guide you through that has a database of 700 plus eating disorder informed providers across the country of Canada. And so if you feel like you're looking for support, if you're looking for support for someone in your life, know that you're totally willing to either call in or chat in, and you'd get the same level of support from some of our trained support workers.